treat to have my colleague, my partner here at Ohio State, Dr. Sameek Roychowdhury, who is really a national expert in cholangiocarcinoma and in targeted therapy, and really, a go-to person to treat patients with this disease. So Dr. Roychowdhury is associate professor here at The Ohio State University, where he's also the medical director of our cancer genomics lab. And as I noted, he really is not only but many people's go-to person, not just here, but from around the country here in the United States for treating patients with advanced cholangiocarcinoma. So Sameek, we're really happy to have you here today, and I'm very much looking forward to your talk.
Well, thank you so much. I really appreciate the introduction and enjoyed the presentations today. Always like to talk about cholangiocarcinoma with our colleagues. And so as Tim mentioned, we'll talk about the systemic therapy advances that we are seeing. What are the standards? What's new? Where are we hoping to go next? And so we'll start with the types of cholangiocarcinoma. Just one slide about the anatomy and how that kind of affects the subclassifications in terms of genetics of cholangiocarcinoma. We'll talk about the first-line therapies and how that is evolving. And then we'll talk about the additional therapies for subsets of intrahepatic cholangiocarcinoma. So this is a diagram I like to start with. And again, I think many of our speakers are experts on this anatomy, but it really helps us think about the disease, the prognosis, the surgical approaches. So obviously intrahepatic, perihilar disease, extrahepatic disease, and certainly gallbladder. It helps us remember that when we see the clinical trials data, that we're really putting together a variety of diseases, and some of them behave a little differently. And it's important to consider as we look at the data that's coming out of clinical trials for systemic therapy. So a few take-home points based on that anatomy. Again, most clinical trials don't consider the difference when it comes to systemic therapy. When it's metastatic or we're looking at adjuvant therapies, they're all lumped together. The larger trials are international, and that influences maybe the inherent disease types. So anatomic types may vary, epidemiologic associations may vary. For example, fatty liver disease patterns may vary. So the types of cholangiocarcinoma will be a mixed bag. And again, this is something to consider. It doesn't mean we can't do these large international studies, because that's the only way we can do them. But it's something to think about when we look at, are there subsets of patients who appear to benefit more or less? And that may be a clue. And so until more recently, this has been the standard of care for advanced or metastatic intrahepatic cholangiocarcinoma, the combination of gemcitabine and cisplatin. And so compared to gemcitabine, this is the overall survival on the y-axis, time in months since randomization. And what's exciting is there's been some new developments with combination therapy with immunotherapy. And so again, remembering that there's a mixed bag of disease here, but around 80% of patients get some kind of benefit, and it does translate into a survival benefit with the doublet combination. And more recently, in the Topaz trial that's been reported and published, we're starting to see other combination approaches. So there's an ongoing study including Abraxane, which is going to add some toxicity, but it may increase the overall response rate. So particularly important for patients who are young, who can tolerate triple therapy. We're starting to think about Abraxane and neoadjuvant therapy, where you're trying to get a good response so they can become a surgical candidate. And we'll talk about PD-1 combination therapy next. Other first-line clinical trials that are happening are looking at, the sequencing of FGFR inhibitors. We'll talk more about those before chemotherapy, and is there a benefit to starting with those first line? So this is from ASCO this year and presented many places, the Topaz 1 study. Started initially with a smaller phase 2 study, and now it's become a 600 patient plus study, again, of the doublet chemotherapy, gemcitabine cisplatin versus gemcitabine cisplatin with the addition of durvalumab, a PD-L1 antibody therapy. And what's really exciting, and you can just see here with the red curve, which is the immunotherapy arm versus the blue curve, this is overall survival. And on the x-axis is time in months, and we're seeing what you've seen in the previous slides about gemcitabine cisplatin, but we're starting to see a tail of longer term survival. This is 27 months, but we'll see how these patients fare further out. But there's a subset of patients who are gaining benefit with immunotherapy, and the metrics here are on the right, overall survival. But what's interesting is that there's a tail, and we want to see how far this tail goes out for durable disease control for metastatic disease. So we're excited to see how far that goes. And the addition of durvalumab doesn't really add a lot of toxicity compared to, say, the addition of a third chemotherapy agent. Certainly there will be toxicities from durvalumab, but most patients tolerate that pretty well. So I know in the US, many of my colleagues and I have started to include durvalumab. The metrics for this approval around the world vary. And so this survival benefit doesn't always meet the criteria of certain agencies. And so we'll see what the follow-up data is, hoping that this could be approved in other parts of the world. But in the US, we're definitely very excited to offer this to first-line patients, even patients who had already started on GemCis who have been benefiting. I've added durvalumab as well after 6 months or so. And so we're really excited about this combination therapy. So immunotherapy in cholangiocarcinoma, when it's been used in a single agent strategy for second or third line, we know it's benefiting 5 to 15% of patients. And again, this is where that anatomy and diversity of disease comes into play. Although I would say this metric of 5 to 15 is probably similar to most solid tumors for metastatic disease getting, PD-1 immunotherapies. This is a nice review published in Lancet summarizing some of these immunotherapy studies. But again, the average benefit is around 5 to 15%. So before incorporating this in first-line therapy with GemCis, I would pretty routinely use single-agent PD-1 immunotherapy in the second or third line setting. One, patients are going to benefit, and two, it's pretty well tolerated, especially in cholangiocarcinoma where, second, third line disease, it can be, people can accumulate toxicities and lose their performance status. So this, again, another slide, just summarizing the tremendous activity worldwide for immunotherapy, especially immunotherapy combinations, because the single agents had not been as promising with the 5 to 15% response rate. So we'll continue to follow these studies. Many are combining it with a second immunotherapy agent. Some are trying to modulate the immune microenvironment. A lot of activity happening in cholangiocarcinoma. And then returning to our anatomy, we'll shift over to sort of molecularly guided therapy. So instead of the chemotherapy, immunotherapy for all approach, we do know that cholangiocarcinoma is really one of the poster childs now for precision medicine. And we can associate some of these anatomical regions with some expected genomic targets. So FGFR, we're now saying 10 to 15%, IDH, maybe 15 to 20%, BRAF oncogenes about 1%, ERB family oncogenes about 1%, EGFR alterations, maybe less than 1%, and then NTRK probably less than 1%. And all of these are quite actionable. Some of them carry a tumor agnostic approval in the US, and then 2 of them have a cholangiocarcinoma specific drug approval. For the other anatomic subsites, they have a different genomic profile. These tend to be more KRAS mutations, so very similar genomically to pancreas cancer, extrahepatic and perihilar. And then the gallbladder variety tend to have more epithelial growth factor gene alterations like ERB family and EGFR. So here are a couple updates on FGFR. For a disease, 5 years ago, we didn't have this many drugs. And so we've seen 3 years in a row an FGFR drug approved in the spring. First pemigatinib, second infigratinib, and now futibatinib, a covalent inhibitor as opposed to a reversible kinase inhibitor for the FGFR gene. Here's one of my patients on the infigratinib study with her pre-treatment scan on the left with a nice response of disease in her lungs, and then her main liver mass responding very nicely. On average, we think about 70 to 80% of patients will benefit from an FGFR drug, with a smaller fraction getting a partial response, and then the majority of patients getting stable disease. But that might be changing. And so, we have a dearth of a great variety, thankfully, of second generation FGFR drugs. There's been some new data presented by Relay Therapeutics that was a lot of excitement about. And what we're seeing is higher response rates. And that's not unexpected. When we have a first-in-class kinase inhibitor, it's not necessarily the best in class. And so we've got the first-in-class inhibitors. And so maybe we're going to inhibit the targets more effectively now, as well as deal with resistance mutations that we know emerge in these patients. And so this is just highlighting maybe a 25% partial response rate and maybe a 50% stable disease rate with infigratinib in this waterfall plot. You can see highlighted here, and this is the dimensions and tumor response for infigratinib. So I want to highlight one patient from this study just to kind of link the world of surgery to systemic therapy. Chemotherapy isn't necessarily the only neoadjuvant strategy we have. And so this is a patient who was deemed unresectable, had chemotherapy, didn't tolerate it very well, didn't have a response, joined our clinical trial for about 8 to 10 months, had to stop therapy for a number of reasons, but had a good partial response in the first 8 months. He was reevaluated for surgery, and he underwent resection. And so it's been a little more than 2 years post-operatively, and he's done well. We monitor him with MRI every 2 months with blood markers as well. And so unexpectedly, a patient who was pretty unresectable to start with had such a great response to FGFR therapy. And so I think we have to remember and keep our minds open. We never know what kind of responses we're going to get to second-line therapy in cholangiocarcinoma. And so beyond the FGFR alterations, which are for the most part in bladder cancer point mutations, so this is the FGFR gene in a cartoon fashion. In cholangiocarcinoma, we see mostly fusions, and that happens here in green. But we're starting to learn that there are other cholangiocarcinoma patients that don't have the canonical FGFR2 fusion, and they're actionable and treatable. And so we're starting to see patients have FGFR3 alterations. We're starting to see extracellular alterations in the immunoglobulin domain, small mutations, small deletions. And then another category that we've seen in pediatric cancers that we're looking now for in adult cancers, there are also tandem duplications in the kinase domain. So I think all of these are potentially, if observed in cholangio, potentially actionable and should be considered. And it's an area of active research from our team and others. So a couple highlights. I think we're near the end. I'll just stay on schedule. Molecular testing is essential for cholangiocarcinoma, and it can certainly improve outcomes, survival, and response rates with good side effect profiles. We should always include RNA-seq because that's the best way to detect fusions for the most part. We're still pretty tissue-based in terms of testing. I still recommend tumor tissue-based testing, cell-free DNA if you can't get tissue, but cell-free DNA, we know, can miss FGFR fusions, and that's well documented now. So if you've done cell-free DNA only testing and you can get blood, you can get tumor tissue, please consider getting tumor tissue for your patients. And the last thing is we should start to consider these atypical alterations that are not the classic FGFR2 fusion. I think Got a couple more slides. So I'll just highlight a couple other targeted therapies. IDH has emerged in about 15% of intrahepatic cholangiocarcinoma. There's a survival benefit with ivosidenib. It's very well tolerated in terms of side effects. BRAF was studied in a larger group of patients, and here's about 40 of them, which is a subset that represents cholangiocarcinoma. Excellent response rates. This is published 2 years ago with Vivek Subbiah. And so again, well-tolerated therapy. This is something we should always be looking for. While it may only be a percent or so of cholangiocarcinoma, highly actionable and patients are benefiting. So to summarize, we're excited to see the new systemic therapy opportunities, potential for combinations in cholangiocarcinoma, highlighting again, molecular testing is essential. A lot of that's related to anatomy. We're seeing an evolving landscape of first-line therapy with PD-1 immunotherapy. We'll see where Abraxane data falls out, but we're excited about that. And then additional therapies. Again, molecular testing is key for our patients with intrahepatic cholangiocarcinoma. And thank you for your time. I look forward to the question and answer discussion later. Always happy to talk about cholangiocarcinoma.
Thank you so much, Sameek. I really appreciate what is a great overview of all the various therapies, cytotoxic, immunotherapy, targeted therapies that are emerging to treat this challenging disease. So thank you. Our next